Alrighty. Hi, everyone. Thank you for joining today. We're going to go ahead and get started. So my name is Katie Gertis, and I am the Assistant Director for Alumni Relations in Health Sciences. Thank you for joining today's Pitt Health Sciences Virtual Health Academy. We have a wonderful group of doctors with us today from the Department of Psychiatry from the University of Pittsburgh. Today's topic will be focused on improving treatment for stress and anxiety. So before we dive into it, I just want to address that we should have time for Q&A after our panel discussion. So I just ask if you can utilize the Q&A feature to ask those questions, and we will sort through those and ask as many questions as the time allows. So with that being said, you will first hear from Dr. Rebecca Price. She is the Associate Professor for Psychiatry and Psychology. And Dr. Price's research centers on developing and testing new brain-based treatments for anxiety, depression, suicidality, and compulsive behaviors. She is also a licensed clinical psychologist with expertise in evidence-based psychotherapy. It is my pleasure to pass it along to Dr. Price to introduce today's topic and learn more about the impacts, prevalence, and main treatments that are currently available.
Thank you so much, Katie, for that kind introduction and also for the invitation to be here today. Also, thank you all for joining. I'm really excited to share some information on this topic with all of you. I also want to take the opportunity to thank my esteemed colleagues in psychiatry for joining me on this panel. I'm just going to give a very brief overview of the topic, and then what I'm really looking forward to is hearing what my colleagues have to say on this topic. So clinical anxiety disorders and other stress-related mental health conditions, such as, for instance, depression, are the most prevalent mental health disorders worldwide. So these are, in fact, so prevalent that every one of us on this planet knows many people who will struggle with these conditions, sometimes in silence. And usually, if we ourselves are not among those who have experienced them directly, then we know multiple people within our own close circle of families, friends, and colleagues who are struggling with one or more of these. So if you see here for the lifetime prevalence of clinical anxiety, if you know 3 people, you probably know someone who has met the full clinical diagnostic criteria for one or more anxiety disorders in their lifetime. And these disorders include anything from specific phobias and social anxiety to generalized anxiety and worry, to post-traumatic stress conditions, to things like obsessive compulsive and related disorders. And then many other mental health conditions, depression being the most prevalent one, but certainly far from the only one, could be described as stress-related, as they also have a very strong stress-related component and tend to be initially triggered and also wax and wane throughout one's life in accordance with stressful life events. So first thing I want to highlight is just that first and foremost, there's a very staggering human cost of these conditions on our patients, our families, and our communities. These are conditions that sap away the capacity for many of our most fundamental human experiences like joy and bliss and connectedness to others, experiencing a passion and purpose in life, and replace those with pervasive feelings of dread, despair, and loneliness, just to name a few. We can also quantify a staggering toll of these conditions on society. So in the case of depression alone, we're talking about the #1 cause of disability worldwide because depression is so very prevalent and so very impairing. Then if we add the total cost to society of these very, very prevalent, even more prevalent anxiety conditions that I spoke about, what we get to is a number of a cost of about $1.15 trillion per year to society. And this is lost because of the 12 billion days estimated of lost productivity that they've robbed from us. We're also talking about 1 million lives lost to suicide every year, and this is rising. And so many of us also have felt acutely the impacts of these conditions in recent years. And you'll hear people speak about the second pandemic of mental health conditions that seem to get only worse in the context and the wake of the COVID pandemic. So I want to emphasize too, our focus today is on improving treatments. But there are numerous effective treatments available for depression and anxiety. And these include medications, psychotherapy, and even some newer approaches that are FDA approved, such as certain forms of neurostimulation. So if you or someone you know is struggling, help is available today. But we also undeniably have quite a lot of room for improvement. So by some estimates, only about 13% of patients actually receive what's considered minimally adequate treatment for these conditions, let alone receiving optimized treatment. And another estimate is that about 60% of young Americans, children, adolescents, young adults who have severe depression receive no treatment at all. So we're having challenges with getting these treatments out to people who need them. So we know that there are some challenges that create problems with accessing these treatments initially, as well as maintaining them over the long haul. And so just to highlight a few of the areas that are room for improvement in my view. One is that conventional treatments typically take 6 to 8 weeks to reach a therapeutic effect, meaning people are left vulnerable while they're waiting for the therapy to kick in. And so we can't address very, very urgent clinical needs, like, for instance, a suicidal crisis. Also, with our kind of more conventional first-line treatments. And this is also compounded by the fact that, unfortunately, not all patients are helped by the first treatment they try, or even by the first several they may try. And this leads to a need to return to a provider again and again using a trial and error approach to try to find something that's going to help. This creates a demand for mental health care that far outpaces the supply, particularly because our treatments tend to require experts to administer them. So therefore, they can't be rolled out easily into settings where healthcare workers are already stretched far too thin, or, for instance, rural or more remote areas. And then lastly, we also still have a sizable percentage of individuals who are going to ultimately be considered treatment resistant, meaning that they can try several evidence-based treatments that have been helpful to others and not receive that benefit themselves. And so we really need novel approaches that can help that proportion of patients. So I will stop there and get us right into the panel to hear everyone else's thoughts on these topics.
Awesome. Thank you so much, Dr. Price. So we are going to go ahead and move along into our panel discussion. So at this time, I would just like to take a moment to allow each of our panelists to give a brief introduction on themselves. So if you all want to turn your mics and your cameras on, and we'll go ahead and get started. Awesome. Dr. Andreescu, why don't you go ahead and start us off?
Sure. Hello, everybody. Carmen Andreescu. I'm a professor of psychiatry. My expertise is in late life anxiety and depression and various interventions that can help people who suffer of these disorders.
Dr. Brent, do you want to go ahead and go next?
Sure. My name is David Brent. I'm a child psychiatrist at Pitt and UPMC, and the area I work in is in depressed and suicidal adolescents.
Wonderful. Dr. Burmacher?
Yes, I'm a child psychiatrist at Western Psych and UPMC, and I mainly work with anxiety and mood disorders in children and adolescents.
Wonderful. And Dr. Brown.
I'm a clinical psychologist and associate professor in the medical school, associate professor of psychiatry. And I work with, I treat depression and anxiety in medical patients, specifically in patients with chronic pain disorders.
Perfect. Wonderful. Again, well, thank you so much for all being here and sitting on our panel today. So that'll lead us right into kicking off our discussion, and we'll address our first question. So we'll have the opportunity to hear from each of our panelists and their insight and their perspective. So our first question is, what do you see as being the biggest problems we still need to solve within the current treatments of these conditions? And Dr. Bermacher, do you mind kicking us off?
Yes, if I divide the treatments into acute, prevention, and how to prevent recurrences, one of the main problems that we have is that the treatments that we have, both therapy and medications, they diminish the symptoms a lot, but the person usually remain with some subclinical symptoms, which increase the risk to have recurrences. Then we would like to have treatments that the patient will go into something that we call remission. Also, we would like the treatment sometimes, especially the medications, to be more specific for the condition, because many of these medications go to the brain and act in many places, and then sometimes cause side effects. Also, we would like the people to be more aware that the treatments exist, and especially the misconceptions that they have for the treatment in psychiatry, and it's still a lot of the prejudice that the community have and the families, etc., regarding psychiatry. Finally, there are still problems with insurances, then sometimes they don't cover the best treatments that we have, in contrast with medicine in general. And the availability of treatment is not always there. For example, cognitive behavior therapy, we already know is very good for anxiety and depression, but in many places, there are not people certified to provide cognitive behavior therapy. Or, for example, there are not enough child psychiatrists in order to prescribe the medications or do the therapy, and then the waiting lists are very long. That's it. Can you hear me?
Katie, you're muted.
I was muted. I apologize. That's my fault. Dr. Brown, if you don't mind going next.
Well, I think Dr. Bermacher must have seen my list because he covered it all. But I do think the three major challenges I see in the populations that I serve, and one of them has to do with the specificity, as Dr. Bermacher said, of the medications. Right now, there's often a trial and error approach, and people get discouraged. I do try in my work, I do try to do education about medications as much as I can. And sometimes, a lot of times over time, discussing people's concerns and biases, they're willing to try it. But I think that specificity in terms of getting the science to have more specific medications so people don't have to try 3 and 4 medications to get the right one. The other has to do with access. I think that is one of the biggest challenges. We have great treatments, but we are still challenged in terms of people getting access to those treatments. One thing has to do with the location, trained therapists to do them, payment for therapists, as well as people being educated about how treatments help. There's a stigma associated with that. Very often I talk with people about it in terms of developing coping skills. Medications help with the symptoms, but very often people have to work with uh, uh, improve their coping skills. The last thing, and I've encountered this uh, sometimes with our medical populations, is ways to have developing proficiency in with patients who speak a different language. We do have interpreters, and that works in an initial interview, but it doesn't quite work as well if you're trying to do therapy, because you're not really developing that direct relationship with the patient. You're talking to the translator, they're talking to the patient, and they're not talking to you directly.
Awesome. Thank you so much. Dr. Price, what are your thoughts on the situation, on the question?
You asking me?
Oh, yeah, Dr. Price or Dr. Brent, that's fine too.
Oh, okay. Sorry, I didn't quite
Go
get it.
ahead, David.
All
I
right.
already got to go first.
So I agree with what's been said. What I would add is that while we have evidence-based treatments, the work that's been done generally focuses on one condition at a time. And that isn't really the way people present. They have usually multiple problems. And I don't think, and there are approaches, but they aren't as well taught or disseminated about how to find out what's really important to people and how to sequence treatments. And I think that that's something that we could do a lot better than we do now. The second thing is that our reimbursement system, and I say our general orientation in the United States, is towards treating something after the condition is developed. The evidence base for prevention is very, very strong, and the effects are much stronger than they are for treatment, but yet they're not reimbursed. They're not, you know, widely used. And I think that if we could allocate our resources in a way that we could provide evidence-based prevention where it's needed, I think we really could make a big difference in terms of lowering the morbidity for the conditions that Dr. Price talked about.
Thank you. Dr. Price, did you want to go next?
Sure. I don't have too much to add beyond these really important points that my colleagues have raised, and sort of some of the points I hit on in my opening. But just one kind of theme to tie into in terms of this idea of a trial and error approach, that's often what's needed, and the kind of complexity of patients with multiple things going on. I think that those issues are compounded by the fact that the response to a given treatment isn't often immediate. So it's kind of going to take time to see whether what a practitioner is trying is helping what for a patient to see and understand whether it's helping, and then to maybe switch gears and try something else, so that those kind of inefficiencies in the time delay before you can really assess whether something's helping or not. When you combine that with the need to maybe do some trial and error and try multiple things, then you're looking at just a lot of delays in people feeling that their needs are being met. And as Dr. Brown eloquently pointed out, the discouragement and frustration that can, and hopelessness that can happen in that scenario. And then, you add that together with some of the payment reimbursement challenges. And, so there's multiple of these things all kind of working together to create some of the biggest challenges in my mind. So I think if we could see results faster, or get an earlier signal of whether something might really be the right approach for a given patient, and if we could also leverage more tools that help get treatments that work into the hands of people without necessarily relying on highly trained experts to mediate that. So for instance, digital tools, then I think we could reach a lot more people who are struggling today.
Thank you so much. Dr. Andrews-Q, did you have any closing thoughts on our first question?
I completely agree with my colleagues. I think, yes, we do not have causal treatments. Our treatments are symptom-based, but they're efficacious treatments, and that's something that I think patients sometimes in these trial and errors that may take months, they and the providers may forget about that, and the length of the trials indeed can be discouraging. Except for there is one additional point I'd like to make that comes from my experience with older patients with depression and anxiety. It's not only access or diminished access to care, but also this diminished education when it comes to what can be treated. For some reason, the idea that older people should get more anxious and sadder because or more depressed because that's part of life is something that I encounter pretty frequently. And that's another big barrier to access, to treatment access that I would like to emphasize.
Awesome. Thank you so much. I appreciate everyone's insight. So we'll go ahead and move on to our next question. So our next question is, what are a few innovations or approaches either right now or on the horizon each of you are excited about? And Dr. Brown, do you mind starting?
My comments have to do with access and support/education. I think the access to care is improved when we integrate behavioral health into medical practices. People may not, the medical conditions are often a life stressor, particularly as people get older. And they don't necessarily see themselves as having a psychological or psychiatric condition, but they do understand that they are distressed. So that gives us the opportunity to get right in there and educate them, get them into treatment. Also, what it also does is people talk to other people. So they can educate others about their experiences using behavioral health care. I think that that's a plus. And the more we can do that and be able to fund behavioral health providers in these medical centers, the more access people will have. The other thing, telemed is the second access issue. We had started using telemed before the pandemic, but before, it was typically in rural populations where people couldn't get into the clinic. With telemed, we had a quick switch. With the pandemic, we had a quick switch to telemed. And I think that that has improved access to a lot of people if they have the computer service to be able to use it, to be able to use those digital services. And the last thing is peer support. Having peers who are educated about the conditions, who have experienced that, and who can share those experiences with our patients helps them to understand some of the barriers, may help reduce some of the stigma in seeking care and remaining in care.
Thank you so much. Dr. Brent, what are your thoughts?
Well, one of them was what Dr. Brown talked about. I think actually, in terms of access to care, that's probably the single most important thing is integration with primary care. I would say some of the innovations there, in addition to delivering therapy by telehealth, I think there's also growing evidence that digital tools can be helpful. Apps, a lot of them haven't been well studied, but there are those that have been and that provide a supplement to therapy. And so I think that that's one innovation that I think is quite important, particularly in younger people that are, tech savvy. And related to that, there's ways to use different computational methods from data that you get from cell phones or from social media to identify people who are struggling. And this gives us the opportunity to perhaps be able to push interventions just in time when they need them. And again, particularly with the population I'm used to, kids whose behavior is often very impulsive, the idea that you could have a tool that would respond to people in real time could be life-saving.
Thank you. Dr. Andreescu, would you like to go next?
Sure. I'm coming from a research-rich environment, and the things that excite me the most are related to opportunities to use things like neuromodulation, but targeted neuromodulation based on, let's say, objective markers that we got from looking at how the brain works, and use those markers to target things like transcranial magnetic stimulation or other forms of neuromodulation that are easy to tolerate, easier to tolerate sometimes than medication. Sometimes they have a signal that they may work faster, that they may continue to have an effect even after we're done, after the treatment is over. So all these things are pretty exciting from my perspective. Also, the combination of these options, these treatment options with new molecules that are in the pipeline or are already used. I think I'm going to let Dr. Price tell us a little bit more about that, because it's one of her areas of expertise too.
Wonderful. Dr. Price, did you want to go ahead?
Oh, sure. Thanks for the setup. Yeah, Carmen knows me too well. Yeah. So what am I most excited about? Definitely some of the biological agents that look to have, at least preliminarily, a more rapid and yet enduring effect on symptoms. And so, some of these are definitely more on the horizon, as you put it, Katie, in the question, whereas some are available now, not necessarily as your first treatment to try, but maybe, for individuals who have tried several of the more standard conventional medications or psychotherapies and feel like they still need more help. There are things available such as intranasal S-ketamine, intravenous ketamine. These are available options in clinics today that seem to have a much more rapid effect on symptoms like depression and anxiety. And then there are others further down the line where we're seeing a promising signal in some of the early studies, and these include things put into the term of psychedelics, so things like psilocybin or MDMA. There's a lot of potential and excitement around that potential in the research realm. And so perhaps we will see those become clinically available options if they prove to be safe and effective over the longer haul of the research trajectory. Then another area that's that I consider in a similar vein are some of the TMS, transcranial magnetic stimulation approaches that Carmen already alluded to, which again are designed to act more rapidly. So there's something called accelerated theta burst stimulation is a fancy terminology for a study, a protocol of neural stimulation that's being studied and looks to have, some rather large and very rapid effects compared to the kind of older protocols that are FDA approved and available. So any way that we can make our treatments more efficient through, hopefully a more and more sophisticated understanding of the neuroscience, those are some of the things that I'm intrigued about. Also, using that same knowledge to look for synergies between what can a biological agent like a medication or neuromodulation do hand in hand with a behavioral or learning-based approach, whether that be something that a therapist does in conjunction and in synergy with that, or even a digital tool that's designed to work together. I think we can get more efficiencies there if we can kind of think more logically about how things can work hand in hand and address these problems from multiple angles at once.
Wonderful. Thank you. We appreciate that. Dr. Burmacher, do you want to close us out?
Yes, I agree with everything. Then there is not too much to say, except I want to take the opportunity to mention that some people think in psychiatry we don't have enough knowledge about what we are doing and the treatments. And sometimes in psychiatry, there are more randomized controlled trials for the illnesses that we treat than in medicine. For example, like in pediatrics, I think the stimulants have much more research than any of the medications in the study of all pediatrics together. The other thing I want to mention is that we keep talking about trial and error, but we are not the only persons who do trial and error. If you treat hypertension, for example, we know medications that work for hypertension, even partially, but you do a lot of trial and error until you find the best dose and the best medication. We do exactly the same. But now in this moment, we have very good treatments with very good evidence about how the medications that work for anxiety, depression, ADHD, and you mentioned, and they're taking the limitations I mentioned before. They're very good treatments. We see people completely changing their lives, not only to them, but also their families. I work with kids, and it's hard to have a kid with problems at home, but you treat the kid and the family as a whole also improve. And then the treatments that we have now are wonderful and with very good evidence. And then again, the kid doesn't respond completely, but the same happens in medicine, except for some particular treatments. But I want to emphasize that the trial and error is to find out what's the best treatment for the person. And we wish, for example, in the future, it's still not available for the public, and because we need more research, if there are genetic studies, neuroimaging studies who will help us to choose the best medication for an individual. And finally, we are beginning to develop what we call risk calculators. Risk calculator is like a mathematical model that you can decide what's the best treatment for an individual, because most of the studies show is like they show the average response to medication X, so psychotherapy X. And in this moment, as I'm sure many of you, when you go to your physicians, you can see that they enter variables into the computer, and the mathematical model can say, for you, the best treatment is X, Y, and Z, or even to know the risk of recurrences of cancer or any psychiatric illness, etc. We are beginning to do the same in psychiatry, is what is called personalized medicine, and we are talking now about personalized psychiatry treatment.
Awesome. Thank you so much. We appreciate all your responses. We have one more question planned before we can go into the Q&A portion with our audience. So my last question for you all is, how do we ensure that both currently available treatments and new treatments are accessible to those in need regardless of community status? How can we improve access to these treatments for our underserved communities? Dr. Brent, do you mind starting us off?
I don't mind, although I think I'm going to be repeating some things that people have already said. I think that providing care outside of the mental health specialty sector, I think, is critical. There's evidence that the treatments are more accessible and more effective, particularly in minoritized populations, if they're delivered in primary care. But there are other, less traditional settings, schools, churches. I think that we need to provide care in settings where people are comfortable getting them. And then I think people have also referred to the issue of task shifting. So not every aspect of treatment has to necessarily be delivered by a specialist. People with a lived experience, I think, can certainly provide navigation for people in trying to deal with a very complex mental health system. And And then I think the idea of providing different ways of accessing treatment, whether it's online or through apps and some alternative ways, particularly when people have difficulty accessing care, through traditional methods.
Thank you. Dr. Price, we'll pass it to you.
Sure. So I think I just definitely want to reiterate what many have already said about, the quality of the evidence for the treatments that we do have available. And, don't ever want to neglect to emphasize that we have really great treatments for these conditions available. And as many have been saying, much of the time there's some challenges with accessing those treatments, and where we need innovations to help ensure that people can access them. But also when it comes to developing newer kind of innovative treatments, I think one important and often overlooked element is to really do the community engaged research and kind of approach things with the end goal in mind from the very earliest stages of how will people use this, what will they want to use it, does this meet the needs of our communities, does it meet the needs of our providers? So those elements of research, I think, often aren't wed together with especially with your more kind of pharmacological or more brain-based or neuroscience approaches when they're being developed. And so we need better integration and interdisciplinary collaborations to ensure that, that things that are being developed in the pipeline are going to be acceptable and feasible within all of our communities. And, more kind of even more broadly than that, just thinking thoughtfully about the challenges in disseminating treatments, whether they're the ones that we already have or brand new ones. It's always very humbling to hear researchers who really focus on dissemination and implementation, getting treatments into real settings, talk about things like how hard fought the battle was simply to get physicians to adopt hand washing on a wide scale when that was a newer idea. So we cannot overlook how challenging it is to kind of move the needle with an entire healthcare system. And the more that we can incorporate that mindset about how we can partner and talk to all the stakeholders, the insurers, the patients, the providers, the whole picture, to ensure that what we're developing isn't just for the academics to see, but that it actually has an impact in the real world and works in the system that's out there in the real world.
So thank you so much. Dr. Brown, we'll hear from you.
I agree with what's been said by Drs. Price and Brent. I think one focus should be a concerted effort for community education and engagement, so that people can self-understand what's going on with them. I think we need to help people to normalize the experience of distress. That's part of living. And help people to understand, when does it get to the point where my coping strategies are not working and I may need to seek evaluation or treatment. And we need to do that in settings, as Dr. Brent said, in which they're comfortable. So depending on the population, that may be in a community center. It may be in the schools. It may be in the church. When I've done those kinds of activities, people are very, very receptive. And they actually share very personal information in that comfortable, safe setting. And that way people can, and if you think about, one person may tell 5 other people about, I saw this talk and I think you should look into this. Now if you had 50 people times 5, you have 250 people who know a little bit more about distress and how to get care. And what we want to do is educate so that we can also dispel the stigmatizing myths about getting treatment and have people make it readily available. And the education method should fit the group. Like for younger people, digital, social media, really be focused on getting good information out to different populations.
Thank you so much, Dr. Brown. Dr. Andreescu or Dr. Burmacher, do you have any closing thoughts on our last question before we open up the Q&A?
I only want to add that definitely education and very early in life, even at school, about mental health and the availability of treatment, and also that there is still a lot of stigma, and also in different types of communities or like minorities, especially minorities usually sometimes don't come to psychiatry. But I also agree with David that there are few child psychologists and child psychiatrists, then training other people is super important. But the problem, I think, is like how much the pediatricians, for example, get training. I don't know, for example, my knowledge is that the training is minimum. And then even now they're treating nurses, teaching nurses how to manage psychiatry, but also the training is also minimum. And this is my own experience. But finally, that the other thing is that the pediatricians, for example, they have like 15, 30 minutes to see a patient. And then if people come with very easy things, so when people come with a sore throat and everything, maybe 15 minutes is enough. But for psychiatric illness, 15 minutes equal to nothing. And then they need more time and they are overwhelmed with the amount of patients. And finally, is the issue of insurance. Insurance is, sometimes it's not easy. Not everyone has insurance. And sometimes people have insurance, but insurance is not the greatest. And the waiting list is huge. Sometimes you get an appointment in 6 months, and then the problems cannot wait, especially if you have like severe like mental health problems or like conflicts at home, issues of suicide, etc. Then all these things needs to improve. And then it's not only then a psychiatric problem or a mental health problem, it's beginning to be a socioeconomic problem, a political issue that we don't solve this with treatment. Maybe they need treatment, yes, but this is something that it needs to be solved in order to be able to provide with treatment to all the populations. And I'm talking here about the United States. Can you imagine other countries when sometimes you have one child psychiatry and maybe 500,000 kids? Then actually we are spoiled here. But in other countries, it's even worse than what we have here.
Thank you. Dr. Andreescu, did you have any closing thoughts?
I'd like to kind of resume what my colleagues said and to emphasize that we definitely need to pick our battles. There are things that seem like obvious to us, but they're hard to do, like reforming the system or addressing mental health parity with insurance companies, or increase the number of doctors who are specialized in child psychiatry or general psychiatry or geriatric psychiatry. 6 months used to be terrifying 2 years ago. Can tell you that now some of my patients struggle to find a provider, and the waiting list go beyond 1 year, which makes, again, very little sense when you think the kind of symptoms that they have to they suffer with, and the repercussions of those symptoms in their families and in the society at large. But I also like to just emphasize again that there are other ways which are seem easier, and they may go longer in terms of impact, and again, educating the primary care providers and the community at large, and addressing, using treatments that are tailored for your patients. For example, teenagers, younger adults do well with apps, with online treatments. They communicate differently. They respond faster. Older people, not so much. They don't really sometimes feel comfortable in, not all of them, but most of them prefer a one-on-one in-person consult, which can be tricky to find. So, but these are all, let's say, steps that can help a lot, while they do not address the, let's say, the dysfunctions in the bigger system. They may have a real impact on the quality of life of our patients.
Thank you so much. So we do have some time for Q&A with the audience. So just a reminder, if you do have a question, go ahead and put it in the Q&A chat box at the bottom of your screen, and that way we'll be able to see it on our end. So one question that did come through, and this is open to anybody, so anyone, any of the panelists, go ahead, you could feel free to answer the question as you see fit. The first question is, do you value gene site testing for determination of medicine choices?
I can say very quickly, not yet. It's something I wish it would work, but there is no evidence in this moment. Then don't waste your money yet. Then and actually has unintended consequences. Then my suggestion is don't do it yet. There is other ways to check which treatment is the best for you, but maybe in the future, but at this moment, I highly recommend not to do it.
I agree. It's kind of a waste of money.
Great, thank you. Another question we have is, does the panel have any insight on how anxiety and depression can be treated when it's caused by large external factors that can't really be fixed?
I think it can be treated with therapy. It depends on the severity of the illness. It depends on the symptoms, but it can be treated with behavioral methods, therapy, and or medication. Many of people may have experienced trauma, etc., due to a flood or something like that, and they have those symptoms. Psychotherapy would help them, and it may be that medication is also appropriate.
But then I only want to emphasize that also there are many types of depressions, and depression can be normal, it's part of life. Then if the person is demoralized and doesn't fulfill criteria for what we call major depression, then the therapy definitely socioeconomically, and try to improve the socioeconomic status of this person, support, etc., can help. The studies for medications is something called that we call major depression. And very quickly, I want to give an example. When I used to work for Doctors Without Borders, I went to places that they were really, really poor. And there was a lady who was poor. If you name him poor, living with 5 kids in a place smaller than my room. And then her depression, and she, despite her condition, she couldn't even was motivated for any support or any help. Her depression improved with medications, despite that it was triggered by terrible environmental conditions. And she improved. And when she improved, she was able to use all the support that was offering to her. Now, it is not sufficient, because the treatment also needed to involve helping her to get out of the hole where she was living, both economical, socially, etc. But then again, you have to make your good diagnosis, which type of depression you are managing.
Thank you very much. Thank you, Dr. Brown. Thank you, Dr. Vermaher. So our next question actually is for Dr. Andreescu. We have someone asking, what are a couple of tips? Oops, I'm sorry, I just lost it. What are a couple of tips for how we can help the elderly in our personal lives to get treatment for depression and anxiety? So it seems like this generation that never wants to maybe address their personal life with professionals. Do you have any tips for that?
I have a few, yes. And thank you for the question. One of them has to do with never judging the way they feel, never trying to lecture them about, well, you actually are you're anxious or you're depressed, when they use different other words. For example, I've seen a lot of my older patients, they don't like to say they're anxious or they're worried. These are stigmatizing words, words that convey weakness for a generation that like to convey strength. And they would use other words such as stress. Stress is, for some reason, it's much more neutral in terms of how they feel judged about being exposed to that. And then they would feel more at ease to discuss about the things that stress them out, the things that concern them, how they feel in their bodies. A lot of anxious older adults experience this through symptoms in their bodies, and they will talk about it. Sometimes they will say that actually there is a medical illness behind it, but they would be willing to discuss those things. The way that I found it successful to approach it is to kind of describe any kind of therapeutic attempt as an attempt to kind of help them become more resilient, help them become more resistant to whatever stressors are in their environment. And that may help them to be more open to receiving treatment. Again, and another thing, their relationship with a primary care doctor is very important. Sometimes we actually just treat them through their primary care doctors. We discuss with their physicians about what would be a better option in terms of medications or therapy. And the patient prefers to, have a doctor, one doctor that they know for a long time and they trust, than, some academic they see once or twice a year that uses fancy words and they don't understand very well. So there are ways in which this can be done, but it has to be thoughtful to the, let's say, the strengths and the weaknesses of that generation.
Awesome. Thank you so much. We appreciate your response. So we do have time for just one more question. Dr. Brent, someone does have a question for you. Do you have any tips on explaining to a teenager that side effects for a recommended medication could potentially be tolerable if the medication works to support them? So for example, if they are afraid of taking medication.
I don't think I would approach it that way. I think I'd start by saying that the choice is theirs about whether or not to initiate medication. I mean, unless you're talking about some kind of a psychiatric emergency, and that it's my job to try to explain to them the advantages and disadvantages of the medication. But it's really their own value judgment to determine whether the side effects are an issue. So, for example, if you have a kid who's sexually active, the sexual side effects of antidepressants are going to be a lot more relevant than if you have a kid who's not sexually active. So I think it's a discussion. You could say it's a negotiation, but I think that your job is to educate the kid and the family about what the benefits are and what the risks are, and then it's up to them to decide.
Thank you. I appreciate it. So that is all we have time for from the audience. We do have a few more questions, so hopefully I'll be able to pass these along to our panelists, and maybe we can provide that feedback that some of you were all looking for. But just to sort of close us out for today, I just wanted to say thank you for all of you, all of our panelists, for sitting with us today and discussing this topic that I know, and sharing your insights and your expertise that I know is relatable for many. So at this time, you're free to log off. You can see the slide here is my information. So if you have any follow-up questions, feel free to email me and we will do our best to get answers to those questions. And thank you for our audience for participating in today's Health Sciences Health Academy. So you're all free to go, and thank you again. Have a wonderful afternoon.
Thank you.
Thank you.
Thanks.
Yeah.
Bye-bye.
See ya. Bye.